Thank you, Doctor, for joining us in this case study video series, an educational initiative by Himalaya Baby Care. As India's #1 doctor-prescribed baby care brand, we strive to uphold the highest standards in every step of our journey. This case study, Clinical Approaches, Sickle Cell Anemia, focuses on advances in diagnosing and treating sickle cell disease in the pediatric population. We are honored to have Professor Dr. Bharat J Parmar, Professor and Head of Pediatric Department at Zydus Medical College and Hospital, Gujarat with us. Professor Dr. Parmar will share his expertise and valuable insights from a unique case highlighting innovative approaches in pediatric hematology.
Greetings of the day. Today I will present a case on a sickle cell disease. Recognized globally, it presents significant challenges in the clinical management due to its complex pathophysiology. This case will highlight the clinical presentation of sickle cell disease in a young patient, outlining the diagnostic steps, management strategy, and ongoing challenges in the treatment to emphasize the key aspect of the patient care in sickle cell disease. A 9-month-old boy presented with acute pain in his finger accompanied by a recent history of an upper respiratory infection with no prior medical issue or ongoing medication. His symptoms raise immediate concern for the sickle cell complication. Swelling and pain localized to his left hand pointed towards vaso-occlusive event. Sickle cell disease characterized by sickle-shaped red blood cells that disrupt blood flow, commonly present with episodes of pain and swelling in young children due to microvascular blockage. These cases indicate the pathophysiological effect of sickling, which frequently lead to severe complications in children. The diagnosis of sickle cell disease in his patient was confirmed through a combination of clinical assessment and laboratory testing. Peripheral blood smear analysis revealed the hallmark sickle-shaped RBC and other signs of hemolysis. Sickle cell testing, including the sickling test and hemoglobin solubility test, indicated the presence of hemoglobin S. Hemoglobin electrophoresis provided definitive diagnosis showing a high concentration of HbS with no detectable adult hemoglobin, confirming a homozygous sickle cell genotype. Such a genetic profile places the patient at high risk for frequent and severe vaso-occlusive crises, anemia, multi-organ complication, making early diagnosis crucial for managing sickle cell disease. Sickle cell disease results from a mutation in beta globin is replaced by valine producing hemoglobin S. Under low oxygen condition, hemoglobin S polymerizes, leading to RBC adopting a sickle shape. These cells become rigid and obstruct capillary, causing tissue ischemia and recurrent vaso-occlusive crises, which are often extremely painful. The complex pathophysiology includes anemia, hemolysis, inflammation, multicellular adhesion, and increased blood viscosity. In this patient, the hand pain and swelling are a characteristic of hand-foot syndrome common in young sickle cell disease patients. This condition occurs due to the ischemic damage in small bone and often exaggerated by infection, dehydration, or hypoxia, as seen here with the recent respiratory tract infection. In this case, the following therapeutic interventions were implemented. Pain management. The immediate treatment for vaso-occlusive crisis involved hydration to improve blood flow and reducing RBC sickling. The pain relief was achieved through NSAIDs and opioids as a necessary and a common approach for acute vaso-occlusive crisis in sickle cell disease. The infection control and prophylaxis. Due to increased risk of infection caused by splenic dysfunction, and this patient was administered vaccination against common encapsulated bacteria including Streptococcus pneumoniae and Haemophilus influenza. Prophylactic antibiotics were also introduced to minimize infection risk which exaggerate vaso-occlusive crisis. Monitoring and supportive care. Regular monitoring of hemoglobin level, reticulocyte count, and liver function was recommended to assess anemia and organ function. Continuous care also include hydration, oxygen support during hypoxic episodes, and education on avoiding triggers such as cold exposure and dehydration. Management of sickle cell disease is tailored to prevent and manage acute crises, control symptoms, and reduce complications. Therefore, let us look at further treatment options. Blood transfusion support. Though not initially required, chronic transfusion therapy is often recommended in the patient with recurrent crises or complications. Transfusion helps reduce HbS level, improve oxygen delivery, and lessen the risk of vaso-occlusive crisis. In severe case, exchange transfusion is also considered to rapidly reduce sickle cells. Hydroxyurea therapy. This myelosuppressive drug was prescribed to stimulate fetal hemoglobin production. HbF inhibits HbS polymerization, thereby reducing vaso-occlusive crisis frequency and its severity. Hydroxyurea is commonly used in young patients due to its safety profile and has shown effectiveness in decreasing the need for hospitalization and blood transfusion. Crisanezumab. This targeted therapy is a monoclonal antibody that prevents vaso-occlusive crisis by inhibiting p-selectin mediated cellular adhesion. Administered intravenously, crisanezumab represents an advanced treatment option that addresses the underlying mechanism of vaso-occlusive crisis by blocking sickle cell adhesion to blood vessels. Bone marrow transplantation offers potential cure, especially for young patients with compatible sibling donor. However, due to limited donor availability and the risk associated with bone marrow transplant, it remains a less common option. Managing sickle cell disease requires comprehensive and individualized care, considering the variability in clinical presentation and severity. While traditional treatment focus on a symptomatic relief, newer therapy including hydroxyurea and crisanezumab are advancing sickle cell disease care by targeting specific pathological mechanisms. Despite this advancement, patients still face significant health challenges, and ongoing research is needed to develop more effective, accessible treatment options. Thank you.
We hope you enjoyed this session and found it insightful and impactful. Thank you. Himalaya Baby Care proudly launches pure cow ghee range with pH 5.5, specially formulated for baby's sensitive skin from day 1, that promotes skin immunity, offers an anti-inflammatory effect, protects the skin's microbiome, provides intense moisture, deep hydration and nourishment, formulated with pH 5.5. Looking forward to your valuable prescription support for Himalaya Baby Care Pure Cow Ghee range.